It's a pleasure to be here again, and my job is to get you out before 4 o'clock and in time so we can win an iPad mini. Okay. I have nothing to disclose. First of all, we want to talk about, really, we all know exercise is good for you, but how good is it, right? We have to convince our patients that it's good for them, and I want to give you the evidence to show them that it is good for them in many ways. So these, as you know, are the risk factors for having atherosclerosis. So genetics, obesity, diabetes, aging, inflammation, dyslipidemia, hypertension, smoking, hypercoagulability, novel risk factors. So what's affected by most things? Physical activity can have great effects on reducing inflammation, reducing diabetes, reducing obesity, reducing dyslipidemia, reducing hypertension. So with that being said, we'll look in detail about what we can do. So to know anti-atherogenic effects are implied by the reduction in plasma triglycerides and improvement in HDL. The anti-inflammatory effects we see when we see documentation of reductions in CRP in many studies. We can tell effects of endothelial function in the lab and in the animal studies. And importantly, reduction in not only anti-ischemic effects, but antiarrhythmic. They do have antiarrhythmic effects from exercise. Endothelial function improves, the weight, insulin sensitivity improves, people get down on their insulin levels, they can prevent diabetes. Importantly, there's a reduction in angiotensin II activity, which, as we know, if we do that, will improve blood pressure. And as well, endothelium production is reduced. Endothelium is the most potent vasoconstrictor we have. If we reduce that, we improve vasomotor function all around, increase vasodilatation, and increase nitric oxide. How does increased nitric oxide occur? Well, as we exercise, we have an increase in plasma catecholamines, increases blood flow and vascular shear stress, which then causes phosphorylation of eNOS, which is endothelial-derived nitric oxide synthetase, which increases nitric oxide activity. Nitric oxide is a very potent vasodilator. So we're having less vasoconstrictor effects, more vasodilator effects, and the overall effect is a reduction in cardiac ischemia. This is very cardioprotective. So we know that exists in animal studies, lab studies, and this is one of the landmark studies in the New England Journal of Medicine to show that actually in a very healthy population of 75,000 women ages 40 to 65 who had no evidence of any cardiovascular events, they were followed for 8 years, and what happened is that if you look at people who were very sedentary, so if you look at the bar where number one is the number of METs the person does per week, a metabolic equivalent is a measurement of energy expenditure, the amount of oxygen that you need in a sitting. So that's number one. When you get up to levels 4 or 5, it's jogging. 5 is more like playing tennis, doubles tennis. 2 and 3 are slow walking, etc. So just with reduction in, you can see a reduction in the risk of cardiovascular events just with even walking. It was statistically significant. They had accounted for 648 events, and this was one of the first studies that showed that primary prevention, right? These women did not have coronary disease, they increased exercise and reduced their risk. So let's talk about people who have coronary disease or other heart disease, and that's cardiac rehab candidates. I think this is just an interesting perspective that this goes back as far as 1772 when Heberden first said, okay, I have a patient coming with me with chest pain. How am I going to make that chest pain better? And what he did is an exercise program with 30 minutes of sawing wood. And the sawing wood, either they just dropped dead if they had a bad occlusion, or they actually got better because they recruited more vessels, right? They dilated their vessels, they had improvement in vascular flow, and that's what we see with exercise. That was 1772. 1779, again, he saw that his patients who had chest pain, but they walked through it. It's a conditioning effect like we do with peripheral vascular disease. You get some discomfort and you walk through it. You actually help to dilate those small vessels. And in 1912, Herrick gave his original description of a heart attack, and he said, oh my gosh, these people their ventricles are gonna rupture. We're gonna put them all in bed for 6 to 8 weeks after heart attacks because that way they won't rupture their myocardium. So that was in the early 1900s, that what was done. And in 1930, Mallory and White looked at autopsies and found, oh my gosh, there's necrosis after an MI, and then it turns into scar tissue after 6 weeks. So maybe we should just make them do nothing for 6 weeks. So what happened in the 1930s is all these people got out on disability. And the labor unions were really upset because they lost all these workers to cardiac disability. And so they approached the New York American Heart Association and said, can you do a study to show that we can actually exercise these people and get them back to work? So that's the long and the short of it. It's all about making money, right? So anyway, so then we say, okay, we know it works in primary prevention. Let's see what happens in secondary prevention. This is a nice large study of 772 men who had a diagnosis of coronary heart disease already, and they looked at whether they had light exercise, moderate activity, or moderate to vigorous activity, and found, importantly, that moderate exercise in men who already had coronary disease resulted in a reduction in mortality. Very important. So reduction in mortality in this study. And this is just a study of exercise, not of the whole cardiac rehab program, which we'll get into. So what is cardiac rehab? It is not just exercise, and it's not just going to a gym, and I think that that's where the downfall happens in clinicians who aren't prescribing it, because it's actually a very comprehensive multidisciplinary approach of not only just exercise, but it's education, it's behavior modification, it returns the patient to not only their full physical functioning, but also emotional and vocational functioning. So when we talk about secondary prevention, so those of you in your offices, so you've just had your stent, you got your radial mechanism to get your stent placed, and then you go to see your doctor and they say, okay, you come to my doctor, we'll get you medications, and then you can just say, okay, lose weight, stop smoking, and go exercise. And that can happen in your office because you don't have a lot of time to go through, really, how should I exercise? What's startup? When can I go back to work? All of that. Well, if you go to cardiac rehab, send the patients to cardiac rehab, they actually learn how to exercise safely, and most patients become much better and have lifelong habit change. There are actually 3 phases of cardiac rehab, and the first one actually occurs in the hospital when the physical therapist is around on 7 East, 7 Center here at Mount Sinai. Our cardiac floors, that's considered really the first phase of rehab. It's monitored exercise in the hospital. And as soon as patients are discharged and a referral goes to the cardiac rehab program, they will schedule an outpatient monitored progressive exercise with very individualized training on several different mechanisms of treadmill, armagometers, rowing machines, with weights, stretching exercises. In addition to that comes education and meeting with nutritionists and psychologists for therapy. Phase 3 is after patients graduate from that program, then they're allowed to come back and have exercise in a setting that's very medically oriented, but does not have telemetry monitoring during phase 3. Phase 3 is usually not covered by insurance, but our patients love to come, and they prefer it to a gym. They use the equipment, they can have their blood pressures checked, there's an exercise physiologist, so they're considered very safe. And these are the components, we're gonna go over this quickly. It's not just exercise, it's a full nurse assessment. We actually talk about health-related quality of life, and we have so much data there. Depression, anxiety scores, let's see, we have smoking cessation, stress management, discussion about what is this medication. Some of our physicians come and give lectures. Okay, what is this? Why do I feel tired all the time? Is it my beta blocker? Why am I bruising all the time, etc.? Okay, usually you should know this: 24 to 36 sessions, 1 hour a week, 1 hour each session. It's 2 to 3 times a week. Every physician at the end of the trial gets an important handout looking at the improvement in overall exercise ability and improvement in lipids, weight, and other modifiable risk factors. So this was one of the first large meta-analysis done in 2004 of 48 trials of cardiac rehab, showing, okay, we know that exercise by itself helps. What about a controlled exercise program that's monitored? And importantly, and everyone should know this, that total mortality was reduced by 20%. So the total mortality was 0.80 in those who had cardiac rehab versus those who did not have cardiac rehab, and these are people who had coronary disease. That was statistically significant, as was cardiovascular mortality. Cholesterol reduced. Systolic blood pressure went down 3 points on average, and smoking cessation occurred. The two things that did not show up here was there was not a reduction in MI, and there was not a reduction in revascularization procedures. Just to show you that in elderly patients are referred less frequently than in younger patients, but even in patients in their 70s and up to their 80s, we had observed versus accrued rates, we had a reduction in mortality. And now finally, and the fellows were excited because in January they said, oh my gosh, look, it really works, cardiac rehab works. Well, it does, and there's it's January of this year, a meta-analysis of 63 trials, 14,000 patients that were randomized into cardiac rehab programs versus usual care. And these patients all were either post-MI or post-revascularization, either with stents now or with bypass surgery. And again, significantly lower risk of death, lower risk of hospital admission, which is very important for our administrators here. But there was no significant reduction in all-cause death, MI, or revascularization. But overall mortality is reduced. Again, in addition to the physiological and the mortality effects, there's a really important reduction in depression and anxiety, increased willingness and ability to go back to work. And these we talked about. I'm not going to keep you for some of these. The indications everyone should know. So Medicare has expanded it a little bit. So you have to have had MI within 12 months, stable angina. So if you have a patient with stable angina, but they really don't know how to exercise, they're not taking care of their overall preventable risk factors, if they have a positive stress test, the Medicare pays for them to do cardiac rehab, a PCI within 6 months, a bypass surgery within 6 months, valve replacement, open heart lung transplant. We have pre-heart transplant patients that come. We have LVAD patients that come. We have other surgery, valve replacements. Importantly, the CHF diagnosis that Medicare covers is an ejection fraction under 35 with symptoms. And no recent hospitalization. So it's it's really our very acute heart failure sick patients, but they definitely have benefits. I'm not going to go through this list, but basically we get referred people all the time who are very sick, really low blood pressures, or very high uncontrolled blood pressures. They have to get that a little bit controlled. It's too dangerous to let them exercise. So what's the problem is nationally, the rates of referral are still quite low, post-MI only 14%. This data was relatively old, but it actually is the same. So it's still post-CABG 31%. Even here, so many surgeons say, oh, they don't need it. They just go home. They'll be fine. Over and over and over again, we hear that they don't need it. You don't need it. I've had a 26-year-old woman in my office who had her mitral valve replaced, and she never exercised because she had rheumatic fever as a child. And she just excelled. And next to her was another patient of mine, 75, who'd been in the gym every day of his life. And he said he learned more from our team than he had ever before. And he became, even healthier. So we have all comers with all different levels. Dr. Rajas Vedanthan does all of our global health research in cardiology these days, and he's been working on issues with global health in cardiac rehab and shows some data that, yes, in some countries it's really abysmal. In other countries, actually in Lithuania, they're really getting it. So the socialized medicine countries tend to refer more because it's not a financial issue. Why isn't it used? People will say, oh, it's parking, I don't want to come, it takes too long, I don't want to, I have to go to work. I have a lot of women don't come because they have family commitments. So in general, women are referred less frequently and they show up less frequently than men. But once they're here, they do very well. So when you're trying to convince your patient to go to cardiac rehab, one of the ways Dr. Vedanthan, this is from him, says, well, why don't you compare it to other things that you would go to physical therapy for, right? So if you had arthroscopic shoulder surgery, aren't you going to go to physical therapy and get that worked on and get into prime condition and get back to a healthy lifestyle? If you had tendonitis in your hamstring, you're going to go to PT. If you had your knee replacement, who would just go home and say, oh yeah, I'll do it on my own? And the doctor say, yeah, just go home, you'll be fine. I mean, really. So those are the things to tell your patient. Those are the things to tell your colleagues. Let's see. Here, our cath lab has been phenomenal at the end of every cath report, right? So everyone's looked at before they're going into the cath lab if they meet all the criteria that they're not. The only people who we can't take are people who are really wheelchair bound or cannot see or cannot communicate well due to dementia or very short life expectancy, those patients, if not, on the CAD report, at the bottom of the report, it will say, we suggest lifelong aspirin, dual antiplatelet therapy, and referral to cardiac rehab. And then we give that to the patient. And the patient then can bring that to the doctor and say, doctor, please, suggest cardiac rehab. So what's happened is actually here at Mount Sinai, we have easy access to through the Epic to order it. We've had some glitches in the last few months. The interesting thing at our rehab is we are actually overbooked. We are booked solid because a couple of other programs in the city have closed. And why are the other programs in the city closing? Well, one is that reimbursement from Medicare is actually quite low for all the person gets. That's a real deal. You get an hour of exercise plus education with trained personnel. You can reduce your cardiovascular mortality, and you get and we get $40. It's really abysmally low for reimbursement. So what we're doing is trying to find other strategies, because phase 3 rehab, we can use that to increase revenue. But that's why a couple of the programs have closed. We're moving to 85th Street between 2nd and 3rd, probably in September. It's a beautiful brand new space, a lot of room, and we'll be happy to see all your patients. And so in conclusion, cardiac rehab is an integral part of secondary prevention. It's underutilized. There's one more thing I have to mention, that there's something called intensive cardiac rehab, which actually Medicare had approved several years ago for the Dean Ornish program and the Benson program from Massachusetts. Those are two programs that if you put into place, you get reimbursed like $150 per session. So it's a much higher reimbursement. What does that mean, though, for the patients? And we're actually looking at it. The Dean Ornish program is it's 8 hours a week of exercise for 9 weeks. So they come in 4-hour sessions twice a week. So it's like half a day twice a week for 9 weeks. And what do? They have a very, very low fat, plant-based diet with 1 hour of learning meditation and stress reduction, as well as 1 hour of exercise, 1 hour of like a chef teaching you how to cook this kind of diet. Very intensive. And we're talking about whether we should do one of these programs. And I thank you for your attention, and let's win our raffle.